So for many years, since I started my lab, I've been working on trying to find the genes that predispose to thoracic aortic aneurysms and dissections, with the idea that nobody needs to die of a dissection. Our current data say that if people with type A dissections, 50% of them never make it to the hospital. And as most of you know, once they get to the hospital, it's a surgical emergency. And if we can figure out who's at risk, monitor the aorta, and repair it in a timely manner, nobody needs to die of those acute aortic dissections. So really what I'm going to talk to you today about is the role of rare variants in genes and highly penetrant genes for this disease, and then how we're taking the genes that my lab and other labs have identified and moving them into precision medical care. I'll have a few slides on what we have really focused in on for the Leduc Award on the molecular pathogenesis of this disease based on the genes that we know cause the disease. And that the whole focus of the Leduc Award is to develop a drug that prevents dissections. We have no drugs that prevent an aortic dissection, and that's a real major issue in the field. So most of you know about Marfan syndrome. You have a single gene mutated. That gene is called FBN1. It was described over 120 years ago. And in the 1950s, it was realized that these individuals with just mutation in one gene had a very high risk for aortic aneurysms and dissections. And now the Marfan syndrome really illustrates that if we can diagnose these people, we can change the outcome of disease. In the 1950s, when it was first described, the average age of death of a Marfan patient was in the mid-40s. And now, because we can diagnose them, use genetic testing, instead of, and know that we can watch the aorta grow to 5 or even 5.5 centimeters, and that they are a low risk for dissection with that growth, that we can change the outcome, and now they live a near normal life expectancy. And as we found the FBN1 gene, we realized there were a lot of people that looked like they had Marfan syndrome but didn't have an FBN1 gene. And now we know those patients, many of them will have mutations in the genes for canonical TGF-beta signaling. And the disease is a little bit different. So finding these genes was the first sort of hint that we really needed to go to gene-specific management. We have to be much more aggressive about repairing the aorta and bring those surgical thresholds even down to 4.2 in some cases. And then number two, once we've hit the ascending aorta, the root and ascending, they're at risk to go on and develop aneurysms in other vascular beds in the brain and branches off of the aorta and so on. So we have to do routine head to pelvis imaging for these patients. And then in addition to that, there's very specific features identified with each gene, like for SMAD3, there's a peripheral neuropathy with aging that's not there with the other genes. And that my patients with SMAD3 mutations that over 70 years that are elderly are all in wheelchairs because of the peripheral neuropathy that doesn't occur with the other genes. So we had some hints as we found these genes that we needed to move to gene-specific management. And even right now, all these are under the umbrella of Loeys-Dietz syndrome, but each gene needs to be managed differently. So, and even within a gene, we have a wide range of clinical severity. So Loeys-Dietz syndrome was actually originally described as childhood onset dissections with cranial synostosis and facial, abnormal facial appearance. But there were also patients that looked like they had classic Marfan syndrome that ended up with a TGFBR2 mutation. And then at the far end, the vast majority of people with TGFBR2, you're not going to pick them up from the general population. They look normal. For many years, the dogma in the field was that too much TGF-beta signaling was driving the disease. But as we found these genes involved in canonical TGF-beta signaling, we're hitting every single aspect of that signaling, the ligands, the receptors, the SMADs, And uniformly, these are loss of function mutations. In some cases, you're just not making any protein from one allele. In other cases, for like the TGFBR1 and 2, we've shown all the mutations are in the intracellular kinase domain, and we have shown they are loss of function mutations. And I think it was a big, I know there's some surgical people, oncology, surgical oncologists here. I think it was a big surprise for the field that germline mutations in TGF-beta signaling cause vascular disease, and not much in the way of cancer in these patients. TGFBR1, the extracellular mutations, can cause squamous cell type cancer. But other than that, no apparent increased risk for cancer. So we've really worked on and described the fact that you can have families that have no syndromic features and still have autosomal dominant inheritance of the disease. And John Ritter died in his mid-50s of a dissection. We imaged his family members looking for those asymptomatic aneurysms, and his brother had an aneurysm, actually was repaired here, and is still alive 20 years later. And it turns out that John's father had chest pain, grabbed his chest and died, and most likely also died of a dissection. So that illustrates that just knowing it can run in a family, we can pick up people whether we know the gene or not, as long as we image for those asymptomatic aneurysms. And we knew early on, so we really started recruiting these families. We're up to about 1,400 families. That translates to about 10,000 people in our study to find all the genes. And we knew early on there was a lot of phenotypic variability, and so that there was most likely going to be a lot of genetic heterogeneity. Here's a family in Texas where there was one person that presented with a dissection, had a huge aneurysm, and then gave us a history. His uncle had a big aorta. And then we went and imaged many of the members of the family, picked up large ascending and root aneurysms, primarily root aneurysms in this family, and went on to do surgical repair of the aneurysms over 5.5 in that generation. I don't know if we're managing it correctly, because whatever's going on with the gene, it's sort of predicting a large, stable aneurysm. Within this huge family, only one dissection. But the exact opposite is this family, all these individuals died and were died of dissection and were autopsied at the same center, and all of them had no enlargement of the aorta. So we have no way to predict in this next generation who's at risk for dissection until we find the gene in this family. So right now there's a large number of genes that have been reported to cause this disease. As with any sort of Mendelian type disease, you have to first validate the genes cause the disease and that you have enough evidence to use it clinically. So here's the list of genes that have moved into the clinic to work through these families. This list explains about 30% of our families, so we still have a ways to go. And I've sort of divided into those that affect the matrix, like FBN1, those that affect TGF-beta signaling, and then down here we have a list of genes that disrupt the ability of the smooth muscle cell to contract, to generate force. And but here's the list of putative genes. So we've reinitiated the validation and we're going through these genes, but you can see there's a large number still following mostly into those three categories, but a whole list of genes down here. And I'll talk about mTOR in a few minutes. And here's some of our unsolved families. So we still have very large families. We did exome sequencing, did not find anything in these families. Now we're going to whole genome sequencing, and even with and have completed that and are analyzing that data. And we now know that there's certain percent of these families that have deep intronic mutations in the known genes. So if you have a Marfan family that tests negative for genetic testing, where they just amplify the exons and not that look through the gene, you need to go on to whole genome sequencing, because every single unsolved Marfan family in our cohort has a deep intronic mutation that by SPICE AI is predicted to disrupt splicing, and the variants segregate with disease in the families. I just want to mention, I'm not going to talk about all the technology we used over the years to find gene, but we actually applied machine learning to identify novel genes. And so that the way that we did this was to look at aortic or vascular specific expression, look at a constraint based on the gene itself and the general population, and then a lot taking the known genes and looking for protein networks. And so we prioritized 155 genes out of the 15,000 in the genome that had those enough information to find the parameters. But we ended up just identifying these 4 genes, that confirming that COL1, that these genes cause disease, including MYH9 and mTOR. So with the mTOR, we already had some data that activation in mTOR was disease causing. So we actually took the variants from our families and set up an assay to determine if these mutations were activating mutations. And here is a known activating mutation that was described in a breast cancer patient. And then you can see that some of these variants are activating, and it goes along with the molecular pathogenesis of the disease. So what I've sort of told you about so far is our success, and in some ways lack of success in finding all these rare variants in genes that cause highly penetrant risk, such that it gets inherited in family. But at the other end of the spectrum is people like Grant Wall, who was the major soccer reporter who actually dissected at the World Cup and died. And then Michael DeBakey, who had his dissection at 94. So, we know in these cases, like Grant had no family history, as did DeBakey. They don't have syndromic features, but we still think there's a genetic contribution. And Stanford, along with Scott Damer's group at Penn, have really done a great job looking at the GWAS signals for this disease. And I'm not going to talk about that, but rather say what happens when we start looking at these patients and look for rare variants in the known genes. And so we've gone in with in collaboration with Scott Damer and Jack DiPaolo. We've gone into the Penn Medicine Biobank and first asked the question: if you take a pathogenic variant in these genes, how penetrant is it for thoracic aortic disease? And what we found was that in the European Americans, the odds ratio was about 9, but that dropped way down in the individuals of African descent. And when you look at specific genes like FBN1, where we know we can pretty well pick up those individuals because of the syndromic features, the penetrance in European descent individuals goes way up, but still doesn't increase that much with people with African descent. We have no evidence that FBN1 mutations are less penetrant in any certain population. And so I think this is perhaps illustrates some health disparities that are there in this population, unfortunately. So we also have asked, if you take a cohort of patients that have aneurysms or dissection, how often do you find a mutation in one of these known genes? And so in our cohort at the top, we took patients under the age of 60 that had no family history and no syndromic features. And we found that 9% of them actually had a pathogenic variant in one of the known genes. And in the majority of those variants were in FBN1. So keep in mind that there's a lot of patients that there's a significant number of people that have FBN1 mutations that don't have syndromic features. And actually, we got the genomic DNA from Grant Wall, and he has one of these deep intronic FBN1 mutations that's predicted to disrupt splicing. And we also looked at type A versus type B, and surprisingly, there's no difference in the burden of rare variants between that. We took it into the Penn Medicine Biobank and looked at dissections there and found almost 12% of their dissections had. But that number dropped way down when we looked at aneurysms, and also dropped down when we narrowed that down to people that had a significant enough aneurysms that they were sent to surgery. So this sort of suggests there's a higher burden of rare variants in people that present with dissection versus those that have aneurysms. And so we've used that to really see if so I think most of you know about variants of uncertain significance, that when you get back testing for Mendelian genes, they're either pathogenic, benign, but you get a lot of reports of variants that we don't know if they cause disease or not. And we wanted to see if we took those VUSs in the Penn Medicine Biobank and asked if we set parameters, could we define parameters that were associated with an increased risk for dissection? So we could say this group, at least this group of VUSs, are highly likely to cause a dissection, and this group, based on the parameters. So using those parameters, we could get almost an 8-fold increased risk of dissection by setting a very low MAF and a Revel score fairly high. And the alpha missense didn't really contribute that much to our predictions, interestingly enough. And we could replicate that data in our cohort down here and partially replicate it in the UK Biobank. But when we went to specific genes, we really could be much more certain that the VUSs were associated with disease, because it varied with different, as you can see with the different genes, there was different risks. So we think this is, for some of the genes, this is a way to classify VUSs that are increasing the risk of dissection, and specifically dissection going forward. And then just for a few minutes, I want to talk about what's going on in terms of the molecular mechanism and what we proposed in the Leduc grant. So we really focused on the genes that are disrupting the matrix and disrupting that ability of the smooth muscle cell to contract. And when we're looking at the genes inside the smooth muscle cell that are disrupting contraction, we're hitting the smooth muscle specific actin, the smooth muscle specific myosin, and the myosin head moves against the actin filaments to contract. And these are, we've shown that these are all loss of function mutations. Then we're hitting the kinase that phosphorylates the regulatory light chain to move the myosin head. And these are loss of function. So once again, predicted to decrease force generation. And once again, we've shown that both in cells and in mice. And then we have gain of function mutations in PRKG1 that control the removal of that phosphate, the myosin phosphatase. And that's driving increased removal of the myosin phosphatase. And all of these come together to decrease the ability of the smooth muscle cell to contract. And a smooth muscle cell, can be decreased contraction because the contractile unit or the kinases controlling it are disrupted, but it still has to hold on to the matrix to effectively contract. So we have really focused in on a structure in the aorta that was described back in the 1970s called the elastin-contractile unit. And in this unit, the elastin fibers send down extension. At the end of these extensions are microfibrils. The major protein in those microfibrils is fibrillin 1, and that's encoded by the FBN1 gene. So right now, the Marfan mutations are disrupting the microfibrils, and once again, some of them are just loss of one allele, so there's decreased connections here. And they connect up to focal adhesions, also called dense plaques, that have integrins in them, and then into the contractile unit. So we've really focused in on trying to understand this unit, which we think serves as a mechanosensor. And then if you have any damage or hypertension, it can start altering genes to repair it. But in the case of the mutations, it never can repair that altered sensing. And with and then the other major risk factor for this disease is hypertension. And in that case, we think that the unit's just chronically overstressed. So really focusing in on focal adhesions, we've defined that FAC is activated in the progression of this disease using a mouse model. And that surprisingly, what happens is the integrin receptors completely change. You go from an alpha 8 beta 1 in that stable situation that's hopefully the case in all of your aortas, to an alpha 5 beta 1, and that's known to drive Row-Rock signaling, but we also find FAC, not surprisingly, will drive mTOR signaling. And this signaling seems to be very responsible for aneurysms, and once mTOR signaling gets upregulated, that's when it triggers a dissection. So this, once again, is the data coming out, and we still have to prove it. The next step to prove the role of these two pathways, but that's what we're finding in our mouse models. And then for the last part of the talk, I just want to, and I just want to mention here that those, that makes sense given that these mTOR variants can be activating and cause familial disease. And then just for the last few minutes, I want to talk about gene-specific management. So myself and Dr. Piritz from Penn and Dr. Guillaume Jandu from Paris launched the Montalcino Aortic Consortium. So we knew about FBN1, we knew about Marfan syndrome, we have 70 years of research on the aortic disease. But as we found these additional genes, and as I already mentioned, there's a wide range of phenotypic variability associated with each gene, and variable management of the aortic disease and the downstream vascular diseases. So we started a very wealthy family in Canada, offered to have the first meeting at their villa and vineyard in Montalcino. And so we named it the Montalcino Aortic Consortium with the hope that we would go back to Montalcino and that they would fund the consortium. And that actually happened. And this was the meeting 2 years ago, and we go back this spring to Montalcino. So just some recommendations: find a wealthy family to fund your research that's willing to have meetings at their vineyard. And I'm just going to go through some of what's coming out of the Montalcino Aortic Consortium. We're up to almost 2,000 patients worldwide in the consortium, and it involves centers all over the world. And one of our initial papers was just to look at the age of aortic events in people with these mutations, and we find aortic events as presentation with a dissection or coming in for repair of an aneurysm. And you can see, looking at this, if we look at those smooth muscle contractile genes, there is a wide range of age of onset, and that with some of them, both ACTA2 and in particular, there is some childhood onset events, but by and large, most of the events are in adulthood. Here are those TGF-beta genes, and you can see that TGF-beta 1 and 2 have the earliest onset, and onset in childhood, whereas when you look at TGFB2 and SMAD3, no childhood onset and much later onset in general. So this has already implications that for some of these genes, we have to be aggressive in childhood, and some we do not. And that if you have PRKG1, which is actually the earliest onset of any of the genes for aortic events, that you really have to manage them very aggressively, and I'll talk more about that in a minute. But even if you, and just to illustrate this, so TGFBR2, by the age of 40, 50% will have had an aortic event, but with SMAD3, it's only 15%. And then we can even go into that TGFBR2 and say, okay, if we have a recurrent variant that we see in 10 or more people, can we start defining even more precisely the age of onset of aortic events? And you can see that's the case, that there is variants that are responsible for that childhood onset. And these tend to be de novo variants also. And then if we look at the contractile genes, we can do the same thing with ACTA2, which is the major gene mutated for contractile genes, and really pull out variants, in particular this arginine 179 that cause childhood onset of the disease. So we've used this, so we've also used the data to determine the surgical thresholds, and all of this for Loeys-Dietz syndrome and for the contractile proteins went into the updated ACC American Heart Guidelines for this disease. So now these guidelines are meant to be the standard of care. So this is the table that surgeons should turn to decide what the surgical threshold is with these genes. And for some of these genes, we need to be very aggressive. And this PRKG1, like I said, is the most earliest onset of events. The events tend to be dissections. They start in the late teens. Shown in pink here are the dissections, and here are the people coming in for aneurysm repair. And this is the exact opposite of what we want to see. We should see people with aneurysm repair coming in before dissection. So there's something very unusual going on with these genes. And the other thing we know is that these dissections occur with no enlargement of the aorta. So it's one of those genes where you will dissect with no enlargement. And so we use that information to manage this family. The mother here had lost her husband and two of her sons due to mutation in PRKG1. We knew that all three of the kids carried it. By the time the family entered our study, the father and son had already passed away, but we found the mutation in these two individuals, and we're monitoring them. And this individual died of a type A dissection at 18, while we were gathering this data on PRKG1. So we went back, we would talk to the mother and the daughter and said, here's the data. And what I'm not showing you is there's no gender difference at all with this gene also, which is important. And so in the end, they decided to go, the family decided to go ahead and repair her aorta at a completely normal diameter. And that's actually what we're recommending, that when people with this mutation reach their mid-teens, to go ahead and the family make a decision as to when to do the ascending repair. But that's a very scary graph there. And once again, it's a common cause of sudden death in these families. And we've looked at the arterial events versus aortic events. Once again, arterial events we define as dissection or repair or rupture, and compared them with vascular EDS, where we know there's a very high risk of arterial events. And so you can see with the Loeys-Dietz genes, they don't reach the same level of events and their later onset than there is with BEDS. And right now, we're recommending pretty aggressive head to pelvis imaging of these individuals, but we're just generating this data, and we've actually combined data with data in France and increased the numbers. So we have FBN1 data here robustly. But I think that we're being overly aggressive doing the head to pelvis every 2 years, and we need to further define that imaging. And then finally, an interesting story came out of the ACTA-2 patients. They have a risk for aortic aneurysms and dissections, but we found also this gene that there's a subset of the variants that cause early onset atherosclerosis. So here's a family where the people outlined in orange all have the variant, and they either have thoracic disease or early onset events, or atherosclerosis. And these are early events. This individual had their first event at 33 with no risk factors. And we have figured out the pathway causing disease, and have, and I talked about that yesterday morning, but we've used that pathway to assay all the variants in the gene. We put them into mouse cells that don't express smooth muscle, the ACTA-2, and we can assay each individual variant, and then take the aortic data, the ACTA-2 patients, and match up the activation of HSF1 and accumulation of cholesterol in the smooth muscle cell with whether or not the family has early onset atherosclerosis. And using this assay, we have 100% correlation and can really specifically define which variants predispose to early onset atherosclerosis. And then finally, there's other variants that don't cause atherosclerosis, but instead cause Moyamoya disease. And that's a disease, I think most of you know, the carotid arteries are wide open until the distal internal carotid artery goes into the brain. And there's typically bilateral occlusion at that location. And this is bad Moyamoya. This young boy had his first event at 5 and had progressive disease and died at 7 years of age of Moyamoya disease. And we've worked on that pathogenesis and are working towards I've started a clinical trial based on why just a few variants in the gene cause this very early onset Moyamoya. And I've worked on, there's one variant, a de novo variant, that arginine 179 that causes early onset aortic disease, but it also causes the children to have Moyamoya disease starting as young as 1 year of age. So it's a very severe disease that goes well beyond the vasculature, but also affects the lungs and disrupts essentially every smooth muscle cell in these children. They're hypotensive, they have fixed dilated pupils because we contract our pupils using smooth muscle cells. Their gut doesn't work properly and their bladder doesn't contract properly. And then finally, we've looked at mitral valve disease in the Montalcino aortic consortium. Mitral valve disease is more common with the TGF-beta receptors and genes, and in particular SMAD3. And then the last thing I want to talk about is that, you know, here in the US and throughout Europe, we have genetic testing to identify these patients. But worldwide, most countries don't have access to genetic testing. So we have drugs that do slow the enlargement of the aorta and delay dissections, don't prevent them completely. And even for vascular Ehlers-Danlos, where they tend to rupture or dissect or the peripheral arteries more than the aorta, we have drugs that will delay those events and extend the life. And so we've moved into trying to use facial AI and facial analysis or facial gestalt to really define the facial features. There's a number of companies that do this also, but they will group all the EDS syndromes together or the LDS genes together, and are not very specific as to which gene is involved. So we've employed neural networks, actually worked with one of the companies in Europe that has worked on the AI and facial gestalt to begin to see if we can just take a picture of somebody's face and really diagnose the disease. And we started out with vascular Ehlers-Danlos, and because that's really causing the earliest onset. And here, shown here is a AUC curve, and based on the number of training images we put into the system and how specific it is for diagnosing vascular Ehlers-Danlos versus the Chicago facial database, which is thousands of people that you can publicly access their images and analyze them. And as you can see, it doesn't take much to be. Actually, by 14 images, we have a very specific definition of the syndrome. And we look versus controls, and the AUC is 94 versus those controls. And then one other question is, can we distinguish it from the more benign EDS? And when we look at that, it actually performs just as well. And what I'm showing you here is there's now programs where you know, AI itself has been a black box. You put the data in and you don't know what they're calling the facial imaging in this case. And before we took it further, we really needed to make sure that they were recognizing what we recognize as physician in vascular Ehlers-Danlos patients: a long, thin nose, a thin upper lip, and sort of deeply set eyes. And then based on the analysis by that program, this is exactly what the program's picking up. And so I feel more confident that what we're doing is valid, but it's the next thing we need to do is move it. This is all based on European descent, and we need to move it into other ethnicities and see if it works as well. So just to summarize, just our clinical recommendation: all patients with this disease aneurysms or dissections need to be informed of the genetic component, and the recommendations are that the first degree relatives be imaged, whether there's a family history or not, because you pick up those asymptomatic aneurysms in the family members in about 1 out of 5 patients. And then genetic testing for if they have syndromic features, and you select the affected person, obviously, family syndromic features, family history, or all aortic dissection cases. And then cascade screening and gene-based management going forward. We're actually working on an app where you put in the gene and the variant, and it spits out the recommendations, but also we'll go into the data and show you the graphs so you can take to your patients and illustrate where the recommendations are coming from. And then if the family history is, there's a family history, and it's negative genetic testing, which is still the majority of the patients with familial disease. The testing is negative. You image all the at-risk family members and manage the disease based on what's going on in the affected family members. And I just want to recognize that I don't do this work without a lot of collaborators and a lot of funding from foundations and the NIH. And been very lucky that a fair number of my patients have turned around and donated to the research. And I just want to show Michael Fishbein and AJ Pedrosa. I don't know if either one of them made it here, but we worked extensively with them on the ACTA2 Moyamoya story to figure that molecular pathogenesis out. So thank you very much.